Welcome, everyone. We'll wait just a minute or so to let others join, and then we'll begin. Okay, we'll go ahead and begin. Welcome, and thank you for joining our NextGen Benefits livecast. Today, we have with us Nelson Griswold, who's the chairman of the NextGen Benefits Network, and Todd Martin, who is the chief sales officer of Nova Healthcare Administrators, Inc. And Nova is our newest NextGen Benefits solution provider. And Todd will be presenting a spectrum of solutions, 7 cost containment strategies to meet your clients where they are. So now I'd like to turn it over to Nelson and Todd.
Kendall, thank you. Welcome to this Friday livecast from NextGen Benefits. It's exciting for me to have Todd Martin with us because they are our newest, as Kendall said, our newest certified NextGen Benefits solution provider, which certifies that they are committed to and using NextGen principles such as transparency. As a TPA, they're unbundled. They're using value-based cost containment strategies. And they've also been validated for performance by the Validation Institute, on whose board I sit. So we've partnered with the Validation Institute to make sure that not only are they saying the right things, but they're getting the results that an advisor and an employer counts on when using a solution in their health plan. So Todd, who has been wanting to say this, CSO, Chief Sales Officer, CSO for Nova, is going to share with us some strategies that help you meet the prospect or your client where they are. And this is incredibly important because you don't want to push them too far down the next gen journey because they'll pull back. You want to make sure that they're getting the level of solutions that they are ready for, they're comfortable with. So Todd, let's take just a moment while we're jumping into the PowerPoint presentation to talk about Nova. Just give a little background about Nova and the key differentiators that our audience needs to know.
Yeah, absolutely. Thank you, Nelson. And thank you, Kendall, as well. It's a pleasure to be here this Friday. So Nova's been around for about 40 years. I've been with the organization for around 12. And when I first joined the organization, we were really just one of those TPAs that paid claims, answered phones, and we have a parent company. And they said, Todd, you got to grow this footprint of the TPA across the country. And when I began knocking on doors, I was really just a TPA that paid claims, answered phones. At the time, we didn't even have a medical management vendor supporting some of our membership. So at the time, healthcare reform was starting to evolve in the individual mandate. We really didn't know exactly what the future of healthcare was going to look like, but we knew that there was always going to be risk-bearing entities. So I would say over the last 7-8 years, we've really become more of, a trend management organization. So our bread and butter business is still working through consultants to self-funded employers. We also support a lot of other health plan startups or TPAs across the country that might have a unique model, might have a unique technology. They really want to focus on building out that technology, but not necessarily run a day-to-day operation. So we can support health plan startups like that. We also support a lot of other TPAs that might just pay claims and answer phones. And they don't necessarily have the technology or the resources to help manage the populations from a clinical perspective. So today in-house, Nova employees, probably about 15% of them are actually registered nurses. We also have a health plan performance department that's constantly looking at all the data of all of our populations, identifying individuals for unique types of engagement, whether they fall into buckets of case management, disease management, but we are URAC accredited for utilization management and case management. And then also using that same data and really looking at it at an aggregate level to identify unique cost drivers within each specific population. And then as we're going to talk today, once we identify those cost drivers, it's really bringing different types of solutions and recommendations to the employer. And Nelson, as you mentioned previously, every employer's appetite for change is a little bit different, right? A lot of it depends on the population that maybe they have. Are they concerned about employee recruitment and retention? Are they concerned about having, that BUCA logo on an ID card? Or are they somebody that's truly looking to dive in, roll up their sleeves, and try and actively engage in controlling costs a little bit better? So it's really understanding what that employer group's trying to accomplish when you deploy different types of solutions to help them meet their goals. So as a TPA, we kind of take a look at our employer groups as old back science days, or if you take a look at this picture, it might make you think of your first Pink Floyd event. But the white light source to the prism is truly the company, right? And what is their appetite for change? What are their cost drivers? And understanding what those cost drivers are to come up with those recommendations. And so us as the TPA, we're pulling all of that data in, and then we're really deploying multiple different types of creative solutions across the board. And so the ones we're going to focus on touching on today is really network solutions, telehealth solutions, wellness strategies, medical management, pharmacy, which is obviously a major cost driver today in the industry, different types of benefit design tiers, as well as reimbursement. So the first one is really network, right? So many of the employer groups that we work with, they're just really focused on the traditional national network access, possibly a BUCA network, where they know that their employees are going to have strong access and they're also going to receive good discounts. But we all know on this call here today, like, what is really a discount? But for whatever reason, many consultants and employers have been trained over the last 15, 20 years that the discount is everything, right? So we work with a lot of national networks, a lot of regional networks, and then we also have employer groups that kind of use a hybrid model where they might focus on the practitioner and ancillary lines of coverage with a PPO, and then maybe do reference-based pricing on the facility to more effectively control the cost of those high dollar claims. And then we have other employer groups that really just kick the network to the curb, all in general, and truly go open access, traditionally in a reference-based pricing model, where they're paying a percentage of Medicare on all claims that come in. So it's funny where we are today, because I've been in the TPA space for the last 15 years. And when I first started, it was nothing but regional networks, First Health, PHCS, and those were the TPA network solutions. About 10 years ago, maybe even a little bit less, Aetna, Cigna started leasing their networks to TPAs across the country. And at that point in time, employers really wanted their employees to have access to every provider and facility in the country, and they wanted that good discount. So a lot of people transitioned over to those national networks. And over the last, I would say, 2 to 3 years, a lot of employers have started to identify that those BUCA networks, they really have a lot of limitations, right? So their fee schedules, they're going up every single year. They have plan design restrictions on the benefits that the members can have. They also limit the ability to do direct contracts within their network. And so I've almost seen a 180 going back to where I started, in that people are transitioning away from these networks because they lose a lot of control. So we're seeing more and more regional networks with our clients again. We're also seeing a lot of employer groups, whether it's a large employer or maybe a broker in a specific area, do direct contracts with health hospital systems, because employers are to the point now where they're not necessarily concerned about their employees having access to everywhere. They're more concerned about them having access to quality care at the right price. So when we do these direct contracts, we're starting to use the First Health again of the world, because the First Health may layer in as a wrap, just in case somebody's traveling. There might be a gap in a hospital system for the services that they can provide. So you can layer in First Health to obviously fill those holes so that people can always have access to in-network care. So the whole network piece has been really interesting to see evolve. I mean, we've had clients transition to reference-based pricing, and it really might not just be a good fit for their population. You know, we had a client in the Midwest. They started with us doing reference-based pricing January of 2020. Everything went great the entire year. The first week of January in 2021, every single person that incurred a claim at a specific hospital system received a balance bill. And so all of these people get balance bills all at the same time. They come into work. They don't even feel like they have health insurance. Now, this is a white collar population. The employer is extremely concerned about recruitment and retention. And they said, you want to know what? We can't have this. We have to transition back. So we transitioned back to the more standard traditional PPO network. But the nice thing about being, you know, an independent TPA is that we have the flexibility to do that, right? So we didn't lose the client. We really just changed the strategy around what they were trying to accomplish. But when we talk about reference-based pricing, I mean, the savings are real, right? Anyone that's done it, they can see it, they've experienced it. But at the same time, too, the employer has to have a tougher skin, right? Because there's gonna be a little bit noise, and they need to work with a TPA and a partner that's gonna help them manage that noise. But at the end of the day, it's not gonna be perfect, but the savings are for real. We just experienced a pretty unfortunate situation. We have a level funded product that you can do reference-based pricing on, and we were selling it through a general agent. So we don't necessarily have the conversations all the time with those smaller downstream employer groups. And so this group went live 1/1. There was a broker change about a month ago, and the new broker I was talking to, the employer didn't even know that they were doing reference-based pricing. You know, so if you're going to do reference-based pricing, education to both the employer, but also the rollout at the member level, that's really going to be the key to the success of it. Because if a broker is going to go in and just sell on cost, reference-based pricing is going to win every day, right? But in this instance with this broker, they no longer had a client 3 months later. So really, reference-based pricing, communication, education, that's the key to the success around that.
You know, Todd, reference-based pricing can work and it can be very effective, but
Yep.
it is at the end of the day a Band-Aid on a cancer, and the cancer is bad contracts. And those contracts are between the network and the providers. So direct contracts, disintermediating the insurance company, getting rid of the network contract and setting up a direct contract that's a win-win for both the hospital and the employer, the payer. I think that's the ultimate ideal. And I think we're slowly but surely getting there. RBP has a place, by the way, for out-of-network claims.
Yep.
Right, where they're traveling, you don't have the direct contract set up. So it's out of contract claims, I guess. RBP works, and it's a great solution for that. But the direct contract route, we're promoting that stronger and stronger in NextGen.
Yeah, absolutely. And where we see it really, I guess, most successful is when you're in a community that really has a two-player hospital system town, right? That's competing for lives. Because if you're in a very rural area where there's only one hospital system, there's really no benefit for that hospital system to do a direct deal, right? Because they know you're not going to go anywhere else. But if you have two hospital systems or even more competing for lives, and an employer can say, hey, I'm going to steer all of my employees and membership to your facility if you give me a direct contract. And they want that, right? Because they know that these members are only going to be going to those facilities. So that's obviously ideal. I couldn't agree with you anymore, Nelson. Direct contracts are the way to go. It's just being able to have the leverage to establish them.
Right.
You know, so another area that we see evolving as a way to control costs is obviously telehealth. You know, almost everybody has Teladoc these days. That's another area we're just, you know, making sure that the members are aware of it and then it's communicated to them. We actually just did a utilization review with our telemedicine vendor yesterday, and we really think that utilization should be higher. You know, so we're developing different types of ideas and throwing them around on how can we better engage the membership to be aware of this benefit. But, you know, prior to the pandemic, you know, primary care physicians weren't really doing any telehealth visits with their membership. But throughout the pandemic, they all have transitioned to this type of model. And a lot of the primary care physicians that I've talked to is they love it because it allows them to really act more efficiently. And then the people that are coming into their office are people that they really want to meet with and sit down with and spend time with. But a lot of just the day-to-day elements, those are things that it can handle telephonically. So most of the employer groups that we work with now do cover telehealth visits with their primary care physicians. Obviously, it's a resource to keep people out of the urgent cares, the emergency rooms. So most of the employers that we work with, they will waive any sort of member responsibility for a telemedicine consult just to drive utilization that direction. And it's obviously, more convenient, right? So you have somebody that's sick, they don't want to drive anywhere. Maybe you have a mother with a sick child. She doesn't want to pack up all the children into the car to go to the doctor's office. So these tools are really nice for the membership. As well as the other thing that's popping up a lot, Nelson, too, is really more telephonic services that are geared towards targeting a chronic condition, right? So there's diabetes vendors out there that have wearable devices that feed back to a health coach and they manage their conditions telephonically. Different types of strategies as well, like a Livongo, right? So a lot of things with technology is truly transitioning to more of a telehealth, but actually a virtual setting like we're talking today, to receive care and become further educated. One of our really good experiences with telehealth, and it wasn't even really telemedicine, it was truly just a 24-hour nurse line. So we brought on a client a handful of years ago, and within the first 6 months, we identified in the claims data that emergency room utilization was off the chart, right? And historically, most people at renewal would say, you want to know what, like, let's increase the copay on the emergency room, decrease it on the urgent care, and try and, steer that membership through plan design. But when we dug down and tried to identify why people were going to the emergency room, it was actually new moms. So there was a lot of new moms in this population. And what we identified is that every time little Johnny coughed or sneezed, mom was running to the emergency room 24 hours a day. So with this population and all of our populations actually moving forward and learning this, we actually would do outreach to that expecting mother during the 3rd trimester of pregnancy. Educate them on the importance of establishing a pediatrician out of the gate, but also letting them know that they all have access to a 24-hour nurse line. So all of Nova's members have access to talk to a nurse for free 24 hours a day. And then we'd actually even mail them out a magnet to put on the fridge that has the 24-hour nurse line and the number. So, next time little Johnny's coughing or sneezing in the middle of the night, pick up the phone, talk to a nurse, let them know what's going on. Maybe it's go to the drugstore and get some Dimetap. Maybe it is go to your pediatrician in the morning. Maybe it's urgent care. But obviously, if it's an emergent need, we want them to get there. But we obviously saw those emergency room trends go down, which ultimately makes for, I guess, a happier consumer, right? Because nobody wants to go to the emergency room, but you're also seeing that benefit on the employer's claims on the bottom line. Another area we obviously see is wellness. You hear less about wellness, I feel like, these days than we did 7 or 8 years ago. I'm a true advocate of wellness if it's done right. If you're just one of those employers that says, I'm going to run a wellness program and I'm going to reimburse everybody that goes to the gym, right? That was like the most popular one years ago. But the one thing that we've noticed is that you're not going to make people move into the gym that aren't going to the gym today, right? The people that are going to the gym today are continuing to go to the gym. Now just their employer is going to pay for it, but you're not getting any change out of the membership, that you need. So we're really strong advocates, obviously, of wellness with rewards, right? So whatever that may be, but we know people move when you kind of dangle that carrot in front of them. So one of the things that we've seen most successful is biometric screenings, right? So biometric screenings, and if there's an incentive tied to it, that's the area where you get people to move, right? Because if there's a differential in your out of pocket of what a person is going to have out of their paycheck on a weekly basis, people are going to take that biometric screening, right? And we're not trying to identify necessarily the people that are already going to the doctor. We're trying to identify those people that haven't gone to a doctor, making them aware of certain conditions that they may have that they probably don't know, giving them recommendations on how they can improve those conditions, and really ultimately leveraging that same data, putting it into the clinical platform and making it a piece of each member's health profile to help us engage better to those that need it. And so we have a client that's been with us for a number of years, but I mean, they basically started out with that same type of wellness program that I was talking about before, right? So there's the gym membership. They had some lunch and learns, people come in and talk, but you're not really moving the needle on the people that you need to move. So over time, they started doing some more incentive-based programs to get people actively moving. Participation was continually going up. Eventually, they started engaging with the spouses of the employees as well to get them engaged with the wellness program, doing the biometric screenings. And if you see down here on the bottom in 2018, this was probably one of the best stories, is one of the employee spouses took the carotid screening, basically said it saved their life because there was obviously a condition there that was unknown. And without that biometric screening, that condition never would have been identified, and that person potentially could have passed away, but most likely would have definitely been a high cost claimant for the employer group. And so the problem is sometimes when we talk to employers, they have a hard time swallowing that fee for the biometric screening, right? They're like, ooh, I don't want to spend $125 for everybody to have a biometric screening. But, you know, at the end of the day, an employer is going to cover blood work for any of their employees. They're going to cover a physical for all the members on the plan. So being able to get them to buy into biometrics and how it's going to overall help them control costs in the long term is truly huge. And so we always advocate for that. And 99% of the time too, if you're working with a self-funded employer, right, you're going to take a look at your stop loss numbers. You're going to look at your premiums, your fixed costs, your aggregate factors, which are your claims. Any stop loss carrier is going to let you bill or pay for that biometric screening as a claim, and it would basically come out of, you know, what your attachment point would be. So it's really getting paid out of the plan regardless. But this employer was, you know, elected as Western New York's healthiest employer. So that was really nice for us to see that we were able to play such an impactful role with that client. Another area is medical management, right? So when we talk about the traditional style of medical management, that's really just, you know, your standard pre-cert list, you know, basically making sure that the services that are being rendered are medically necessary, so people aren't getting duplicative care from multiple different providers, and making sure that providers aren't doing unnecessary services to the membership. So there's also more creative solutions and expanded solutions for care as well, you know, getting creative with those utilization management programs. But, you know, once those pre-certs or prior auths come in, like, what are you doing with that information? And, you know, engagement also too is tough, right? So nurses, what they do best is help people through their healthcare situation at that time. And over the last handful of years, it's getting more difficult to have members pick up the phone, right? People don't pick up phone numbers that they don't know, and they're not necessarily calling back somebody from their health plan. So when we can engage with membership, we are very impactful. So one of the things that we did, starting the first of the year, we ran a pilot program. It's running great. We're going to run it out to all of our clients, but we did an integrated platform with an organization called HealthJoy. And so basically what we're doing now is through the HealthJoy app, which has outstanding engagement, is we're doing targeted messaging based upon where the member is in their healthcare decision-making process, right? So we're doing targeting messaging through HealthJoy when a provider calls and verifies benefits and eligibility. When a prior authorization comes in, we're sending them out additional communication and education and making them aware, you know, that there's case managers here, which is helping us to more effectively engage with our membership. As you know, Nelson, a lot of people prefer to communicate with their fingertips than they do over the phone telephonically these days. So being able to put education in front of the members for where they're at in their decision-making process of their clinical profile, that's been very successful for us as well. And so when it comes to different types of strategies around medical management that might be a little bit more aggressive than others, Nova measures rates of readmission at 7, 14, and 30 days post-admission for populations who engage with our transitional care program compared to those who do not respond to our outreach. And this chart shows readmission rates as a percentage for plan participants who did not engage with Nova's clinical team. That's what you see on the left, compared to those who did within the client's population. So the plan participants who engaged with Nova's transitional care program after inpatient discharge experienced a lower readmission rates at the 7, 14, and 30-day intervals. The next area obviously is a big buzzword in the industry, right? RX management. I would say probably 75% of employers out there can say that this is truly, what's driving the costs. And, a lot of people take a look at the traditional PBM and, they get sold on rebates. So everybody's talking about these big rebate dollars. But I mean, at the end of the day, the discounts and the rebates, they're important. But when you're evaluating your PBM and looking at your formularies, not only is transparency important, but looking at the formulary as well, right? So I want a formulary that's driving utilization to all of the most cost-effective tier 1 drugs, right? I don't necessarily want a tier 1 drug that costs $500 and creates a $300 rebate. I'd rather just pay $20 for the drug, right? So we need to really focus more heavily on what the overall plan is costing and really just take the whole rebate conversation, out of it. So obviously looking at the formulary, managing it that way, but there's also, more of, I guess, the consumer directed model. And a lot of this is really based upon, I guess, the data that we see with the RX management. So that's why it's always important, for a TPA, and we integrate all the data into our clinical platform. So we're integrating the medical claims, the pharmacy claims, the prior auths, the pre-certifications, and really each member has a health profile developed. And within that health profile, we can see when all of those scripts are getting picked up based upon the data that's being fed into there. And so we can identify gaps in care. We know who's not being compliant. And so in one of the situations with us, when reviewing the data, Nova evaluates the medication compliance for members' medication adherence to diabetes. And for one of our clients, it was discovered members were not taking their maintenance asthma meds or picking up their diabetic supplies. And so it was really determined that the cost of the medications and the supplies were an issue for this specific population. So at the renewal, the recommendation was really to eliminate the copays for those items. And the outcome was really an increase in compliance, a reduction in chronic condition related inpatient stays, and ER visits, so lowering the cost of the plan. So in talking to the employer, it's okay, you have these ER visits and these inpatient stays that cost X because people are avoiding picking up these generic drugs or diabetic supplies. We would recommend making this no out of pocket to the member. And so in the future, when we make that change, now you have membership picking up all of those maintenance drugs, taking care of their chronic conditions. And obviously, if we can keep people out of the inpatient settings in the ERs, then those claims consistently are going to go down, which is a win, obviously, for the employer, but not only the employer, for the member too, right? Because they're healthier, they're probably not missing work, they're more productive. So those are some things to really focus on, with the pharmacy side of the house. We also see a lot of employers adding international sourcing type solutions to the programs. We're seeing more people carve out specialty RX and using third-party vendors to try and source those drugs, whether it's through manufacturer programs or, like I said, international sourcing. Most of the employers that we know that do international sourcing, they don't mandate it, but they make it very financially attractive for the member to go that route. And, it's funny, being in Buffalo, 20 minutes from the border of Canada, people have been driving over the border as long as I've lived, primarily Medicare members, to get drugs in Canada, to fill their scripts and bring them back because they could get it, more cost effective. So for me in my backyard, the thought of doing that is kind of normal. But some employers, it's, something that doesn't seem right. So nobody's really ever going to mandate it. But if you make it financially attractive to the member, then obviously, dollars make people move. And so you'll see good utilization on that. The next area is really, I guess, benefit design tiers. And so when I speak about benefit design tiers, there's kind of two levels of tiers, right? So there's the employer level of benefit design, but then there's also different benefit design solutions for the membership as well, and the plans that they might have available to them. So, a lot of times we're really big on like that crawl, walk, run approach, right? So if you have a group that, might not have a sophisticated finance department, maybe just aren't disciplined with cash, and they've been just on this fully insured Blue Cross plan for the last 20 years, right? Throwing them into these unique strategies and plan designs in a traditional self-funded model, that might get scary, it might get overwhelming, you might lose a client, right? Variable claims funding on a weekly basis. A lot of people just don't have the sophistication to do that, so many times we'll bring in a group just on a level funded type solution where the employer obviously is paying what looks to be the same as their previous fully insured equivalent. We're managing all the claims dollars on their behalf. And then over the course of the year, we start talking to them about the data, the cost drivers, things that we may tweak. And, we might transition out of that level funded model at renewal, where we're changing a handful of different things around the plan design. And the same goes for even those employers that don't go into a level funded solution, but typically and most often when we're taking over a fully insured BUCA plan or maybe a self-funded BUCA plan, they're all going to be on these just kind of standard cookie cutter plan designs that, those carriers have provided. So a lot of times when we take over those groups, we just really duplicate their current plan design. Because any broker that's on this call or out there, they'll tell you anytime that you make a change, membership sometimes thinks, the sky's falling. So if we can go into an open enrollment meeting and say, hey, you're going to get a no ID card. We're putting in a network where we know there's going to be minimal disruption. Your benefits are staying the same. That makes for an easier conversation with the employees and with the membership at open enrollment. And so in both of those instances, whether it's, the traditional self-funded standard plan design or level funded, that's really when we can start getting the data. Because a lot of times people will come to us that's not our client and they're like, what plan design do you recommend? And it's really hard to make a recommendation on a plan design when you have no data, right? They might come to us with some aggregate data that doesn't make any sense from the prior carrier. So it's very difficult, to make any sort of recommendation. So over the course of the year, once we start understanding the group, what's driving utilization, what's driving cost, that's when we can get a little bit more creative with the plan designs and really customize them. And that's sometimes where, the direct contract with maybe a specialist in the backyard might come in. So it's fun because everything, that we do, we can bring them in and make it easy and turnkey. But we really have the ability to customize it and really drill it down to the group level to help them accomplish their goals, which 90% of the time it's improving outcomes, but also, controlling costs. So the other area of benefit design tiers, so that was kind of like at the employer level, but I also see benefit design tiers as being important, at the employee or the member level, right? So Nova clients have had success in offering multiple tiers really that meet each plan's participants where they are, right? Some plan participants may want insurance to protect against catastrophic events, right? And they don't mind bearing the risk for the more regular care. So that's probably, the more of the bronze plan that you see up there. They got the higher deductibles. They maybe are putting money into some type of health savings account. But they're good with paying for their annual physical or their occasional doctor visits. But they want to know if something catastrophic happens, they have that protection, but they want less money coming out of their paycheck. Others may prefer the opposite end of that spectrum, right? Where nearly all the services are covered, but they pay a higher premium for the coverage. So through our clinical data and understanding of the client's goals, we're really able to create custom recommendations for each client's, and their populations. And so the last area, and this kind of touches back onto like the bronze plans, is, how can you leverage the different types of funding strategies out there at the member level, right? So if you're that person that wants less money coming out of your paycheck and you're going to take that higher deductible HSA, I mean, there's probably an opportunity for that person, to put a lot of money away in their HSA, right? And let it grow over time, because they don't necessarily have the needs on a day-to-day basis. They don't have a lot of drugs that they're paying for. And it's almost a way for them to create a nice little nest egg into retirement, or just build that up for maybe when the years come and they do need more care and they do have to pay for more costly prescriptions. HRAs as well. You don't see a lot of HRAs in the self-funded space, because why is an employer going to fund an HRA towards a deductible when they could just lower the deductible because they have that flexibility in plan designs? But, we see a lot of employers that we take over that are using HRAs on very high deductible, fully insured plans, right? And so the employer is actually starting to self-fund their plan and they don't even know it, right? So they're putting this deductible as high as it goes to help save on the premiums, but then they're putting an HRA in there to help the members pay for their cost share. Also, HRAs, we can use them as well. Like, so if we're doing those wellness programs that drive incentives, a lot of those incentives can be funded through an HRA, where the member that can then take those dollars and use it for, various medical services. And then also FSA, if somebody doesn't have access to an HSA plan and they're using an HSA, I feel like everybody should really have an FSA, because everybody's really paying for something out of their pocket that's qualified. And, why pay any more taxes than you have to? So the reimbursement account, obviously, all of kind of this is just the do's and don'ts on the different types of reimbursement account options. But I think we all would agree that, there's a trend, and most employers are now offering, an HSA account. And I think that a lot of the members like having access to it for some of the reasons, that I just described. So with that, I mean, that's kind of, the 7 areas that we see to more effectively, control costs, but also customize things down to the employer level. And yeah, you got any questions, Nelson? What do you think?
Well, so there is one question I want to pass on from one of the attendees. We're starting to see hospitals charge a separate facility charge for telehealth. How are you managing the additional cost if you're seeing that?
So an additional fee for telehealth. So I would look at that as probably the same way that we look at physicians telehealth, right? So, and I could be wrong, but I know that when the pandemic happened and this was becoming more and more accommodating, we basically spoke with all of the employer groups and we made a lot of amendments to SPDs. Now, I don't know if there's, obviously when you say facility, typically when I hear facility, I think higher dollar. So I don't know if there would be a differential, but if you get that person's information, I can talk to our plan design team and give them some feedback.
Okay. That's Wade Washington, and I'll connect you guys afterwards. A couple of things. So Todd, thank you for this. There are a couple of points, and I was, when we were going through this presentation prior, doing our setup for this live cast, I love this slide because it's so important to recognize where that employer is. And the only way you know that is to have conversations with them, talk about risk, talk about noise, talk about exposure, and then plan accordingly. The other point I want to make is, and I hope everybody picked up on this, a TPA, a good unbundled TPA, certainly one that's been certified NextGen, can be a great partner in helping determine what those options are and what solutions you have available, and working through those, whether you are bringing the solutions in-house, Todd, or whether you're serving as the TPA and external solution providers are being brought in by the advisor. But using your TPA as a sounding board and as a partner in the plan design and the solution makeup is incredibly valuable. Now, maybe you're an experienced NextGen advisor and you really know all the moving parts. That's fantastic. But the the advantage of having an experienced partner like Nova in this case is invaluable, especially if you're younger in NextGen. Dottie Allen asks, what size groups are you working with, Todd, as a TPA?
Yeah, so that's a great question, because historically, people didn't start talking about self-funding until they were like 300 employees. And, we have a traditional unbundled 24 life group now. We do have a level funded product that really targets, I guess, that 20 to 150 space. We can go up to 200. But what we did with that is we see a lot of level funded products out there, whether it's, a United Healthcare All Savers or a Cigna graded level funded, and they're really nothing more than a fully insured chassis with maybe a couple of additional reports. And then we see a lot of the other TPA, I guess, level funded products. And typically when I take a look at those, when you look at a premium equivalent, it's 80% fixed cost and 20% claims. So there's never really an opportunity for a claim surplus. And oftentimes too, that claim surplus, you have to renew and it comes back in the form of an admin credit. So we have the level funded product that goes down to 20. We'll work with any employer down to 20, but oftentimes what we found with those smaller population of groups is that they want something turnkey. So with the level funded product, we brought in basically what we thought were all the best cost containment tools for a true self-funded plan, but made it turnkey, right? So we have a PBM in there that has a specialty copay assistance program, a value-based formulary. They pass on rebates. So how many level funded programs are employers getting rebates out of? They're all on 12-18 contracts. So there's 6 months of run out built in. And then after that 6 months, 100% of that claim surplus is passed on to the employer. So we don't retain any of the claim surplus, and they're all on contracts that have 125% corridor. So when you take a look at the premium equivalent, there's a significant amount of it that's truly claimed. So the opportunity for a claim surplus is strong. And the other thing that's unique that you don't see in all the level funded programs is that a lot of times you'll see a level funded program, but they don't have a specific deductible. And essentially what that means is one person can blow through the entire claim fund. But if you have the specific deductible in there, that's another area where it's going to increase your opportunity for a claim surplus, because if you have one or two high cost claimants, that bleeding from the claim fund is going to stop as soon as the employer hits the specific deductible.
So one other point, a lot of good NextGen TPAs will have a level funded plan available. And these level funded plans are what we refer to as the NextGen Easy button. So when you've got a smaller group, don't take the time to try to build a NextGen plan piece by piece by piece. Look to find a level funded, already pre-built, we call them rebundled plans. So they're unbundled first, the BUCA plan's unbundled, and then rebundled with NextGen solution providers based around a NextGen TPA. So Nova's got one of those plans. That's something you should look at for smaller groups, certainly under 50. I would suggest under 100, and 100 being the break point where you say, okay, now I'm going to go out and build a plan for a 150 life group. But below that, seriously consider the NextGen Easy button of finding a level funded plan that already has cost containment built into it, but it's fair. It's going to give the employer all of the unpaid claims funds back, and not going to keep half of them like the BUCA plans do. Not going to require you to renew to get your claims funds that were not spent, et cetera. So I'm glad you brought that up. And I'm actually happy that Dottie brought the question up, so yeah, you would answer it that way. The thing I want everybody to understand is there's a reason that Nova has been certified as a NextGen solution provider. And it's because they're doing a lot of things right. And they have the right mindset, and they've embraced NextGen principles. So that's what this certification is for, is to help you know, okay, I've got a lot less due diligence I have to do here. You still have due diligence. Don't take that certification at face value. You still have to ask questions to make sure this is the right solution provider, but you know they're NextGen, and you know they actually deliver bottom line results for your employer clients and for you as the advisor. Todd, any last I've got one question here. At a 20 life group, is the broker charging a fee? If so, how is that structured?
So essentially, all the quotes on our level funded program, they all come out with a line item on there that is titled marketing expense, and that's essentially the broker commission. It's more or less a starting point. If it's something that looks attractive, we can go with it. If you want more or less, we can always adjust it. But essentially what we do is we roll up the broker commission into that premium equivalent. So on a monthly basis, when we collect those premiums from the employer, we're obviously paying ourselves, we're paying a network access fee, we're paying stop loss premiums. Part of that fixed cost will be sending out the broker commission as well, and then the rest of the money gets deposited into the claim count. All broker commissions are reflected on our ASA, just so everyone's transparent and understands that they have to be, but they're flexible. So whatever it is, the last thing we want you to do is lose income on a group by transitioning it over to our solution. So if we need to move that PEPM up or down, we're happy to do so.
So let me suggest thinking of that marketing fee as a fee, not commission, and setting that fee. It's going to be, you're going to disclose it. You have to by law now anyway, and Nova is going to disclose it. So just establish what your fee is going to be, which should be at least what the incumbent's making. I would suggest 50% higher than the incumbent, because you're going to deliver results, whereas the status quo broker before delivered renewal increases, and you're delivering savings as the NextGen advisor. One last question before we go, because I know we're over time. Stacy Gilbert wants to know, how big is Nova in terms of how many members are you all managing?
Yeah, so we probably have about 250,000 members across. So we have a parent company, Independent Health here in Western New York. They're a local health plan. We manage all of their self-funded business. Everything outside of Western New York is branded Nova. So yeah, I mean, we have a pretty good block of business. We've had some good growth. I was employee 36 12 years ago. Now we have over 200. And, we hope to continue to grow the organization. We were actually just ranked the third best mid-sized employer in New York State. So I think that goes off to the culture that we've built at Nova. And I think that a good culture and happy employees results in a good member experience and a good employer experience. So it's just really a trickle-down effect, and it all really starts at the top.
Todd, thanks for your time. It's great to have you as a certified solution provider, and love working with you guys. And
Absolutely.
I will connect you with Wade Washington.
Okay.
Actually, I'll have Kendall connect you with Wade Washington so it gets done. Look, enjoy your weekend. Thanks for all of the information. And we look forward to continuing working with you through the rest of the year.
Absolutely. Thanks for joining everybody
Thanks, everyone.
today. Thank you, Nelson. Have a great weekend, everyone.
Appreciate it.